Thanks for having me come speak to it's certainly an honor and a thrill. And it's a really neat segue coming after Christine's talk, in that Christine's like a really important mentor of mine. And just speaking to that excitement and kind of infectiousness is like, I think it was listening to one of your talks years ago that I was just like totally got hooked. And you've had me here ever since. So I'm really grateful for that. And it's really I've never let go, and it's just like here we are now. This is so fun. So thank you all for inviting me here and for having a listen. And today I'm going to talk about kind of some pediatric perspectives. Just um, in terms of conflict of interest, my only thing to declare is that I'm not only a physician, but kind of a part-time veterinarian. So today I'm going to talk about some mouse data. I also care for pigs and rats and other animals too, but I'll show a little bit of mouse data just to show some concepts and some mechanisms that might be relevant for human disease. The arrows. There we go. So today I'll talk about a little bit of epidemiology regarding some data from Sick Kids Hospital over around a decade. I'm not a clinical epidemiologist, so the data is going to be a little bit incomplete and a little bit fractured, but there's going to be some signal there that'll be interesting to this group, I think, and we can kind of talk about it afterwards. So I'll at least introduce some of the platelet transfusion activity at Sick Kids. And then I want to kind of segue and transition and actually go into a bit of mechanisms and look at some of the pathophysiologic aspects of platelet transfusions and how they can cause trally. And then I'll end with some kind of interesting aspects. We were alluding to some things that are coming down the pipe, and Christine touched on it briefly, which was like how products are stored, including platelets. She didn't touch too much on cold storage of platelets. And that's sort of the extra piece of the puzzle, is that as much as we're going to like change what the platelets are being stored in, it's also how we're going to do it temperature wise. And I think that might even be a double effect that's coming down the pipe. So we'll talk a bit about that. And then I didn't include it in this talk, but I have a little bit of preliminary data around platelet additive solutions with my mouse transfusions, which I'll maybe leak to you guys at the end. So in terms of platelet transfusions, just a bit of an introduction. This is a different study, I think, out of the States, and they looked at 10 years a transfusion at their hospital, pediatric hospital, looking at how many zeros are there? Like almost 6 million patients. And they found like that in general, platelets were transfused around 4% of their patients, and there was a pretty even distribution with sex. And why is he bringing up that already? Well, the sex piece will come back later in the talk, so I just wanted to kind of get that in early. And I wanted to show an approximate rate of transfusion. And when I crunched the numbers with this study and compared it to the Hospital for Sick Children, we actually transfuse probably even a bit more abundantly than these guys do. Critically ill kids have a similar transfusion requirement of almost 3%, 3.4%. And in general, platelet transfusions occur in our oncology population are really overrepresented. And that'll come out, I think, with some of the data that we're going to show from Sick Kids as well. And I really, we'll come back to it, I'm sure, in discussion, but I think the oncology piece is really crucial. When you think platelets, I immediately think oncology first, basically, before I think of anything else almost. So the last thing I want to say is that platelets are associated with transfusion reactions, and of the cellular blood products that are transfused, they really podium. They're really up there. They're much more reactogenic than red blood cells in terms of causing reactions. So I kind of pieced together, we had the number of transfusion reactions over the 10-year period, and we'll get there shortly. But what I didn't have was a denominator for you all. And like that amount of reactions isn't as meaningful unless we can kind of at least guesstimate how many platelets were transfused. So I was able to get a little bit of data showing some kind of monthly consumptions of platelets at the hospital. And when I look at it, I kind of sampled throughout the 10-year period. On average, plus or minus maybe 20 or 30 transfusions above or below, there's around 275 units of platelets transfused a month at Sick Kids Hospital. And if you extrapolate that up to a year, then there's around 3,300. And then over a decade, 33,000 platelet transfusions were delivered. And what was interesting in that little data set that I was able to get my hands on just last week to get this talk ready, I was able to see the locations where these transfusions were occurring, which give me hints as to the populations that were receiving them. So around 7% were the littles in the NICU, And then bigger critically ill kids in the PICU and coronary and the cardiac ICUs received around 10%. And then the hematology oncology population, again, heavily represented with basically half the transfusions, and then kind of a grab bag of everything else, which kind of had the operating room, the emergency department, and kind of some non-oncology ward transfusions. So I wanted to look at other groups first to kind of situate what we found at the hospital. And in general, I think what excited me to go after the platelets was just that of the cellular products, they're so associated with reactions. And in the second part of my talk, I'm obsessed with platelet transfusion reactions. So I was like, I want to go the other direction. Instead of being preclinical, I want to rush over to the other side of the fence to the clinical piece and really test this in my hospital. And I also had inspiration because others have found this too. In general, I think there was that question about kind of pediatric versus adult transfusion reaction rates. Well, intriguingly, others have published showing that pediatrics have a 3 times higher risk of having platelet transfusion reactions, rather all transfusion reactions compared to adults. And pediatric transfusion reactions are associated with platelets, again, similar to adults, like a high association. A lot of the reactions are allergic and febrile reactions. And there's also kind of an interesting association with rare transfusion reactions with pediatrics as well. And again, the final piece, again, I want to keep bringing this up because there'll be some data, is that pediatric transfusion reactions are twice as common in males compared to female recipients. And this is really interesting because when you think of pediatrics and potentially like a lack of really high divergent sex hormone circulating, this is super interesting that there's kind of a sex difference in pediatric patients. So over the 10-year period, we initially captured around 355 reactions, but we were able to exclude around a number of them just because they didn't quite fit in the rubric. So after eliminating the exclusions, we were left with around 336 reactions to work with. And then what I did was I divided by that 336 by the 33,000 denominator, and that's around 1%. So around 1% we're getting transfusion reactions. And again, this is where the data gets a little bit broken, but of the reactions, I can tell you at least that around 1/3 of them were apheresis units and 2/3 were pooled plasma. So what I wanted to do first was be like, how noisy is this over the decade? It's pretty steady in that the number of reactions reported over the decade was pretty consistent. There weren't any obvious temporal patterns to it. And with these little stars on the side, I kind of put some that really caught my attention. Some of the more intense reactions or serious reactions, they weren't clustered over certain times as well. They're kind of evenly distributed across the whole 10 years. In terms of the types of reactions, this is a chart that just shows different grades of severity from non-severe, severe to life-threatening. And we can see again that the bulk of the reactions are grade 1, so less significant. And again, the majority of them are comprised of minor allergic reactions, with febrile non-hemolytic reactions being the second most common. In terms of distribution with age, again, I don't have ultra complete data for this, but what I could do is kind of clump them into groups. And what we can see is that, if anything, kind of a little bit older kids had a fair number of the reactions, the 5 to 12-year-olds, with the second most common being kind of a dead heat between the older kids, the teenagers, and then the 1 to 4-year-olds, with the youngest patients being relatively underrepresented. And again, you can see the kind of the breakdown of the types of reactions. Again, minor allergic reactions kind of being the dominant reaction type, distributed by age. So again, this was interesting and just kind of keeps emphasizing this oncology association, is that really, even though we know from a few slides ago that approximately half the recipients were oncology, 85% of the transfusion reactions were oncology, leaving a meager 15% for everybody else. And so this was like really interesting, again, that overrepresentation with this population, especially seemingly like independent of age, really all the way up into adulthood. In terms of the locations of where the transfusion reactions this time were occurring, we'll remember that like critical, like where the transfusions were occurring in general, if I close my eyes and try and remember, was around 20-ish% critical care settings, and then around 50% in the ward, and then that little bit of other. And what we see here is that with the reactions, again, there's many of the reactions were occurring in the ward, whereas the kind of the higher acuity settings are relatively underrepresented and have really low numbers of reactions, be it the ICU, the emergency department, and operating rooms, where there's potentially a lot of eyes on the patient. There seems to be less reactions, whereas in the ward, this is higher. And that's not completely unexpected, as a lot of the oncology patients would be in that setting on the ward. I threw this in as well, just to be complete. And there's no big discrepancies between the distribution of transfusion reactions and the patient's blood types. And I just put that up against kind of a Canadian Blood Services map of percent blood types, and no big differences there. So I just thought that was interesting. I'd throw it in because I had the data. Now, this was interesting, and I didn't really, going into this project, I just wanted to see like really the numbers and what was there, and maybe to really get an incidence rate for the respiratory transfusion reactions. But I stumbled into this finding, and it's really interesting, and it's going to lead and segue into the second part of my talk, which is I found a sex difference. But the one missing piece of data that I don't have is I'm relying on that one of the papers that I showed you at the very beginning of the talk, showing that amongst transfused pediatric patients who received platelets, sorry, that's a tongue twister, half of them were males. Like there was that 55% were males, leaving 45 to females. I'm relying on our hospital being very similar to that large kind of US hospital. And I don't expect a difference in sex with who is transfused, but I don't have that data yet. So I don't have the denominator to know if it was 50-50-ish in terms of who got the platelets, but this 2-to-1 reaction is super interesting. And I don't have a lot of theories around this yet, beyond what I might show you coming up in the laboratory. So in summary, platelet transfusion reactions at the Hospital for Sick Children are around 1% for platelets in general. And it looks to be pretty steady over time. Males are twice as likely to have a reaction compared to females. And hematology oncology is heavily overrepresented in terms of having these reactions. And I didn't touch on it, but the hematology oncology patients also had some of the higher risk reactions, some of the respiratory reactions or more complicated reactions. The other thing that was interesting is of those kind of special reactions, like the more severe ones, I kind of like did a little bit of looking, and I don't have like the power to make this comment with any certainty, but those were pooled platelets, not apheresis platelets. So a quick little learning break before we switch gears. I'm waiting to hear an audible giggle, or is the font size too small? Okay. So sex-related biology and respiratory dysfunction. With the questions you heard, that I'm really interested in lung injuries in general. And what's really interesting is there are some differences between males and females in terms of lung injury. And they've shown, and it's been well published, that males have worse and more severe lung injuries than females in certain kind of pathogenic processes. And this is well known. And part of it could be that estrogen influences angiotensin signaling, which is involved in barrier protection in the lungs. And another intriguing factor is that females have higher circulating sphingolipid levels of sphingosine 1-phosphate, or S1P, greater than males. And that becomes interesting because S1P is barrier protective in the lungs and helps preserve kind of lung integrity, whereas lower levels can be deleterious and cause leak. And that's sort of going to be the story that I'm going to begin to tell you right now. So again, partly because of Christine, I got really interested. I've always been interested in trally, but like now even more so. If anything, it's like with the knowledge I've gained, I'm increasingly confused, because at first it was so crisp. This is trally. This is taco. That's tad. But it's like in general now I find them all blurring. And I find some of the pathophysiological processes that could be occurring in trally, for example, probably are present in taco. So I like the way we ended the discussion with Christine with a bit of uncertainty and a little bit of diagnostic confusion, because I think all that's super interesting. And that's partly why I go and work with animals, as I try and test some biological mechanisms of how the disease process could work. And earlier we talked about kind of lock and key fits, right? Like about how BNP, when we can get that big delta, is very reassuring. It's laboratory data. We like numbers. We like definitive quantitative measures. And again, how like if an antibody is present, it can be a smoking gun. But what's really interesting is that those dangerous culprit, I like all this legal metaphor we're doing. So those guilty party antibodies, you know, those criminals, sometimes they're present and there's no crime. So there's a lot of TRALI documented where antibodies, dangerous antibodies, are found and the patient's fine, and vice versa. There can be quite a bit of TRALI where it's antibody negative. And that's sort of where the space that I like to work in, is that I think with antibody kind of mitigation strategies, I think we have a handle and approach on that. What I'm really interested in is all these leftover reactions. We haven't eliminated TRALI with strict allo kind of protections. So I think that's super, super interesting. And today I'm going to share some kind of antibody relatively independent kind of mechanisms for TRALI. With this audience again, overlearned. I'm not going to dwell on my TRALI introduction slide, but just to say that it is very common. When you think about numbers, like in the States, up to 20 million people require blood transfusions a year. That's half the population of Canada. And so the numbers of people affected are real, and this can affect hundreds to thousands of patients. And the mortality is very, very high. And I'll just leave it like that. So again, with the mechanisms, we've covered antibodies a little bit, but there's other factors too. And one of them is one of my pets that I study in injury, which is these sphingolipids that I'm beginning to introduce to you. And bioactive lipids in these products can lead to lung injury as well. But really, it takes a vulnerable recipient to set the stage. And I think that's where the oncology patients really come in, is they really fit that bill, to be already inflamed, under duress, and have your system kind of already not in a very robust state. It puts you at a real vulnerability to getting TRALI. So in general, this 2-hit model is well accepted. And even a 3rd hit, because recently we were showing, again, as an anesthesiologist, a lot of my patients are undergoing even a further physiologic trespass, and that even if you're critically ill, and now you have to come in for surgery, and we're going to cut your body and have a big release of cytokines and inflammatory responses to that, it can create even an exaggeration of that 1st hit, or almost a 3rd hit as well. So I'm just putting a lot of emphasis on the patient, even prior to transfusion, brings a lot to the table in terms of the risk of having a reaction. And again, intriguingly, like, why even stop at calling it a surgery? Like having a bone marrow transplantation, I'm used to solid organ transplantation because I'm more involved there, but even a non-solid organ transplantation is almost like that 3rd hit. It's a huge trespass. It's a huge change to the body. And again, here I just want to introduce kind of the compartments that we're going to talk about, which is that there's donors and variability there that can impact how reactions occur, the donor's product throughout the process of storage, and then the recipient. I just want to introduce kind of those 3 components. And here it was this was from a review article where I was looking at extracellular vesicles, which are really interesting because they're almost like little life rafts from cells that bleb off, that they can contain cellular functions and still do potentially harm or benefit. And intriguingly, they're in the plasma. That's in the supernatant, so to speak. But if you want to talk about dust, it's dust, in the sense that we can't even detect them that easily unless you're Jason Acker out in Edmonton and you're like keenly looking for them with complex flow cytometers. So should we go there? Is that what's coming next? Or should we just reduce the plasma? And what are we storing these things in? So a quick sidebar, which we can come back to later in discussion. So how do I recapitulate TRALI in mice? Firstly, what I do is I take a bacterial coprotein and I inject it into their peritoneum. And this sets off, it pulls the fire alarm. It tricks the recipient mouse into what could be like almost like a sterile sepsis. It creates a lot of inflammation, and it creates a lot of kind of systemic activation of neutrophils, which then move into the lungs and take up residence. But we don't get frank lung injury. It's just we get a big heightened vulnerable state until you add the 2nd hit, which what I study is pooled stored platelets that are typically stored at room temperature. So what's interesting is if you look at both mouse and human platelets throughout storage, how to interpret these graphs is on the y-axis is relative change from day 0. So from absolute time of collection, and then storing through 7 days or 8 days for the human one. So kind of a pretty classic storage duration for a blood bank. And what we can see is that these C16, 18, and 20, these are ceramides versus the S1P. I haven't introduced ceramide yet. Ceramide is another sphingolipid that's actually super injurious. And how it works is that ceramides, as you can see with this graph, these are just different chain lengths. So all the red dots tend to increase throughout storage. Whereas the green dots, and I'm using traffic light colors on purpose, the green good go either hover or go down. And there's a big increase in injury with the red and the loss of the green. So ceramide is pro-apoptotic. It'll break and kill cells in the lungs, and it'll actually accelerate breaking down lung barriers and create leaks and create trally. So to test this in our mouse model, what I do is, again, I've transfused those stored platelets. And the tallest bars in the middle, the light gray bars, are just that. Animals that have had the first hit, they're inflamed, they're vulnerable, and then they receive the injurious platelets, room temperature stored 5-day platelets. And these 4 graphs talk about different endpoints for lung injury. There's the wet-dry ratio, which is almost like an edema measure of the lung. How heavy and sodden is it with liquid? The bronchoalveolar lavage total protein, and that's why I brought that up, is that I find this a very sensitive measure to how much leak there is. And what it is too is it'll show you if you're getting extravasation of blood proteins or even cells into the airspace as that number goes up. And then the 2 panels on the far side on the right are MPO or myeloperoxidase enzyme activity, which is like a marker for neutrophil accumulation in the lungs, and then a histological lung injury score. And so what we can see here is, compared to sham animals with the white bars, or animals that are only inflamed but didn't get the second hit, we get this huge rise. And these bars over to the right are when, instead of getting wild type platelets, they were platelets that are genetically missing the enzyme that makes the ceramide. So here they don't get that injurious signal, and they come through and boom, all the injury is gone. So that helps show the evidence of how ceramide's causing the injury. And on the farthest panel, this ARC39 group, that's a drug that will lower ceramide production pharmacologically. And it acts almost like the genetic ablation of the enzyme, and ceramide's lower and there's less injury. So here I'm kind of showing that the only thing I haven't mentioned is, with the little tipping of the scales, I show ceramide but no S1P. Again, because here we know that the S1P is gone. So the message I want to share here is that as you increase that ceramide, you get more injury, especially in the context of missing S1P, and you get resultant severe lung injury in mice. So what I wanted to do is, I'm going to say the enzymes are really hard to manipulate for the ceramide system. I can't change that injurious system that much. I don't have really effective drugs to do that in people. I have some. I can use tricyclic antidepressants like imipramine or amitriptyline, which can work, but they're kind of messy. So I'm going to have a hard time getting that through trials. But what I'm going to do is, instead of trying to take away the bad, I'm going to bring back the good. So as an experiment, what I did is I said, after the 5 days of storage, the S1P is gone. But what happens if I replete that to levels of a fresh platelet pool at day 0, when there's that nice equipoise or balance between the two? And when I replete the S1P right at the buzzer before I hang the platelet bag and transfuse it, trally almost goes away. So by repleting the S1P and reestablishing the balance of ceramide to S1P, even in the context of increased ceramide throughout the storage, we were able to reduce and basically get rid of the trally phenotype in mice. So back to the sex piece. Why was he talking about males and females? Well, intriguingly, in our model, when you look at it, females are protected from having trally compared to males when they face the same challenge. So when I transfuse room temperature stored platelets, and the only difference between my recipients is that one is a male, one is a female, the females do much, much better in terms of injury endpoints. And that was super interesting. And as I began to explore this and unravel it, the answer starts to declare itself with this S1P, or the sphingosine 1-phosphate levels, in that females have much higher levels than males. And this is well documented in humans, that reproductive age females have a lot higher levels of S1P than males. And again, in my rodent model, the same was held here. So it's very interesting that the female recipient, in general, she has a higher amount of S1P present that can kind of offset that ceramide challenge that's brought in. So another little learning pause. So the other thing that we didn't talk about, which is kind of nice because we're going to cover a lot of the topics, is cold storage of platelets. And my interest in this increased recently because some anesthesiologists at the Toronto General kindly let me kind of come into the fold on an interesting story that's about to kind of go live. Is we're going to look at, it's not quite cold storage from the very beginning, which is being done in certain blood banking systems around the world. But there's going to be a trial starting for cardiac surgery looking at delayed cold platelets in cardiac surgery. And a delayed cold platelet is basically a platelet in the blood bank that they're going to take. Oh, it's getting close to expiry. Put it in the fridge. Maybe we can push it. And so it's to extend shelf life. But what I'm going to talk about here isn't going to be that, which we're going to try in Ontario, but rather just cold storage from the very start. And what's interesting is that what we're going to do is take that model that I showed you with the mice, and now what we're going to vary is the temperature at which the platelets were stored before being transfused. And what I'll do is, for this model, I'm going to use male recipients because they had such severe injury, and we're going to really test whether we can kind of take that away or not. This is a super busy graph, but let's walk through it. The key thing that I want to show is that the dark green dots towards the right of each panel are the female recipients of room temperature stored platelets. I put them in again just as a reference because they're going to become relevant for the story. And you can see that those bars are low. And then the bar to the right of that, the red dots, is the injury group. And that'll be the highest kind of across panels A to D, which are those injury endpoints that we've seen. And what we can see is that the blue dots are the cold stored platelets, and they're low just like the female. So when we store platelets in the cold, and that's the only thing we've varied, suddenly we can almost take away the Trally injury. So just as what we're storing the platelets in seems very, very relevant, but also how we're storing them in terms of temperature. And when we go down to the lower panels, I'm going to put some emphasis on panel G first, which is the recipient plasma sphingolipid levels. I know it's really microscopic and the scales are even worse because the S1P levels were a bit lower, but I want to emphasize that that's basically like a little V down there, where the lowest S1P levels are the males who got the room temperature stored platelets, whereas the females, and even more so, the males who got the cold stored platelets, the S1P levels are higher in the recipient. So again, there's that higher degree of S1P related protection. And then when we go to the next panel over, panel H, this is the donor platelets, and I just interrogate the sphingolipid composition in those platelets. We can see that the first two panels show relatively similar levels of the injurious ceramides, which is the LCC and VLCCs, long chain and very long chain ceramides, very similar between the groups, maybe even a little bit lower in the females, which could be protective, whereas the S1P levels are significantly different. The female platelets have, I'm mixing my stories up rather, the cold stored male platelets have higher levels of S1P than the room temperature stored platelets. And the panel over on the very end, was a collaboration with Dr. Dana Devine in BC, who generously provided some cold stored human platelets versus room temperature stored platelets. And when I interrogated those, the same phenomenon. The human cold stored platelets had much higher S1P levels than the male. So this is super interesting stuff that's could be potentially beneficial, is that cold storage of platelets may also be really helpful for reducing respiratory transfusion reactions. So again, there's something really interesting around, I just want to say, like, it's really interesting with Trally and the antibody mitigation, female donors have really kind of gotten a bad rap. And again, antibodies is certainly a big issue. And it's maybe instead of complete diversion, we could maybe even process those units a certain way to kind of get rid of some antibodies. But females may have a really important enrichment in S1P, which is super protective. So I find this research kind of is in its infancy, but I think these sex differences are really interesting. And a lot of it looks to be related to the S1P levels. And further, cold storage is another way to potentially exaggerate that benefit as well and get that increase. And because, I'll talk here with my next slide. So I'm going to try and polish up some of that retrospective clinical data I showed you from our hospital. And I want to kind of push these sex differences even further with the respiratory transfusion reactions and investigate this further. And finally here, I'll say with the platelet additive solution, I've got this. And when I store room temperature male platelets in platelet additive solution, so far, it looks protective, which is fascinating because that's all I'm changing there is the composition of what the cells are stored in. And again, that seems to be a little bit protective. I haven't tried it in the cold yet. We'll see if that has an even greater effect. And again, my findings apply mostly to a pooled platelet product. I haven't looked at other things like lyophilized platelets, which might be coming soon too. So those are kind of all my ideas, a bit of a whirlwind tour and just something different, right? Like thinking about mechanisms of injury. And I want to kind of shine a light on antibody independent trally and to keep vigilance for that. But also like, I'm kind of adding more layers to the onion here, like more complexity, which is that it's like, well, because one thing that's really interesting, I think, is I think that inflammation in some of these sphingolipids are always present in the units and always present with these products. So it's like, I would argue that it's almost an additive model where there's going to be components of each of these contributing at all times. And it's just, is one really going to be dominant compared to the others? Or can you get these almost even distributions? So I think for Christine's case, it's really interesting. I think the platelets did contribute injury and did contribute harm. And it's just like, as you said, like my guess is actually an all of the above to your multiple choice question, which is that I bet all those different pathologies were contributing and one just really kicks it up over like the clinical radar and declares it. Anyway, thank you all for your time and attention.